Hello, my name is Dimple Barolia. I am a resident at White River Health in Batesville, Arkansas, and today I will be discussing the Great Coral Reef Aorta Barrier. To start off, the introduction, coral reef aorta is a rare condition that causes calcifications in the internal luminal part of the artery. Here we present a case involving a female in her mid-60s with a 20-pound unintentional weight loss within the past 2-month span of time. As the case presentation follows, we have a 60-year-old female with a past medical history of hepatitis C and hypertension who presented with memory problems, facial numbness, 20-pound weight loss within the past 2 months, loss of appetite, and also insomnia. A stroke workup, including an MRI and a TEE, showed findings suggestive of embolism and patent foramen ovale, respectively. The CT of the abdomen and pelvis, along with the follow-up CTA, revealed extensive amounts of calcified plaques in the distal abdominal aorta with 50% narrowing. The treatment involved surgical intervention was offered to the patient, however, the patient was lost to follow-up. As you can see from the imaging, I have 3 images here. Image 1 shows a CT angiograph. And you can see the calcifications, as you can see through the pointer here, the white calcifications along the distal part of the abdominal aorta. Image 2 shows a CTA of the abdomen, and you can also see the calcifications around the distal abdominal aorta, as well as a CT of the abdomen showing the same thing. As the discussion goes, the coral reef aorta are calcifications protruding into the lumen of the aorta, predominantly the abdominal aorta, as shown in those previous images. It usually involves the distal aspect of the aorta, including the bifurcation, and can extend into the iliac arteries. Complications may include renal arterial hypertension, peripheral arterial occlusive disease, chronic visceral ischemia causing diarrhea, weight loss, and abdominal pain. Based on literature, CRA presents around the 5th decade of life, and the overall estimated frequency is between 0.6 to 1.8%, and the mortality of 11.6%, predominantly due to visceral ischemia and multi-organ failure. Surgical transaortic endarterectomy with visceral arterial bypass remains the cornerstone treatment. However, it carries significant amounts of morbidity and mortality. In conclusion, our patient presented with weight loss and decreased appetite. Differentials included, but were not limited to malignancy and autoimmune conditions. Investigative studies subsequently attributed the findings to a decreased gastrointestinal perfusion due to extensive luminal aortic calcifications. The pathophysiology of CRA is not fully understood. What is known is that it is a multifactorial disease with multiple potential risk factors, including syphilis, chronic corticosteroid usage, and lack of certain glycoproteins, which can lead to excessive amounts of calcification. The patient's atypical presentation prompted investigation into CRA, which required a high degree of suspicion. This study serves to educate clinicians about one of the various presentations of this disease. Thank you.